कैन यू हियर मी? आंसर आ रहा है क्या उधर से? हम पूरा फुल है, ट्रांसमिट ही नहीं हो रहा है।
हाँ परफेक्ट।
बात करो रे। हाँ, यू आर ऑडिबल सर, एम आई ऑडिबल?
हाँ
कैन यू हियर मी
हाँ,
सर?
राउंड वाला या रेक्टेंगुलर वाला जो भी है
हेलो।
वो है सीट उसमें
Okay,
जाएगा।
can
हमारा
we
front
have
user।
started the
Suppose पानी
relay
आया तो
from the
उसमें
OT?
direct
Can you
जाएगा।
see the OT
नहीं तो नीचे
relay?
गिरेगा, गीला हो जाएगा।
Okay,
पाइप तो
okay, fine,
डालेंगे,
fine.
फिर भी कभी कभी खोल देते।
हाँ, yeah, like we are just preparing the patient. हाँ, patient अभी draping हो रहा है. Patient is being draped. Once the draping is done, we will turn the camera towards the patient. Ah, yes, we'll do that. Good day, syringe and catheter card. सर कहली तुमको सेलिन कही कि वो अनस्टेराइल है।
स्ट्रेट कर दो, स्ट्रेट कर दो, स्ट्रेट कर दो। अगर अच्छा
ठीक है,
अच्छे तो
साउंड बढ़ा दो ना बस। ठीक है। हेलो
एटा ସେମାନେ ଅଫ୍ କରୁଛନ୍ତି ନା କଣ୍ଟ୍ରୋଲ କରୁଛନ୍ତି ତ? ନାଇଁ ଆମେ ଯାହା କଥା ହଉଛୁ ସେମାନେ ଶୁଣି ପାରୁଥିବେ ନା। ବଜ 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 ସେ ତାକୁ କୁହ କଣ୍ଟ୍ରୋଲ କରିବ ଯାହାଟା ତା କିଛି ନାହିଁ ବୋଧେ କଣ୍ଟ୍ରୋଲ ମେକାନିଜମ୍ ଆମର ଏଠି ନାହିଁ। ଆମେ ବନ୍ଦ କରିବୁ। କରିହେବ?
हाँ सर, ये तले दबेले ये लाल ହେଇଗଲେ हाँ। हेलो हेलो, कैन यू हियर? हाँ हाँ, अभी नाउ द साउंड इज स्लाइटली इंक्रीज्ड। हाँ, नाउ इट इज बेटर, नाउ इट इज बेटर। या वी स्टार्टिंग। मानस मानस हेलो, या आई कैन हियर यू। या कैन यू हियर मी? हाँ, या द पेंटिंग इज बीइंग डन। खाली में पेंट कर ना रे। हाँ Yes, 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 sir. We will do that. We are doing it, sir. हाँ सर, आसन. Yes.
ଏଟାକୁ ଅନ୍ କରିଦେବୁ ନା
हाँ ମୁଁ କରିଦେଉଛି.
ପଚାରିବ କ'ଣ
सिस्टर ग्लाइसिन मंगाया क्या? पूछो पूछो, जल्दी चाहिए, लेके आने जल्दी. दे पका 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 सकते.
ଏଇଟା ନାହିଁ ମ ଛୋଟ ଏଇଟା ହେବନି हाँ छोटा वाला चाहिए ये वाला नहीं होता छोटा वाला से जो कटरा रेक्टांगुलर बेसिन गुड़ा न था सेटा हेले बेस्ट बोले एटा बहुत गोड़ लगी देख सी बोला भल ना संडार करिया छोट बेसिन गुड़ा मिले नी प्लास्टिक बेसिन गुड़ा राउंड गोटे थाए रेक्टांगुलर थाए थोड़ा नहीं एटे गोटे नहीं आस हाँ आर हाफ साइज रोड थाए रेक्टांगुलर होगी ना करिया एटा बहुत बसियो ना गोड़ गोड़ लगी ग्लाइसिन हाँ बढ़िया तो एटा फर्स्ट क्लास रखछ तुम केतरा आनल एथु 12टा कौन 3 लीटर जाए गुड़ाक 3 हाँ लगा हाँ हाँ था 4-6टा लगे
Sir, can you please repeat, sir? Hello. Okay. Yes, sir is just coming. He's just washing. He's coming. Okay. Welcome to the yes, sir. Yes.
7 ठीक कुछ बगे एटा गाउन जाए तो किए आमर से क्रिश्चियन हॉस्पिटल अच्छे तंकर ये बढ़िया अरेंजमेंट आमर भी सेम Thank you, Dr. Ajit. They are audible. Ajit? Audible?
Yes, you are very much audible and the voice is very clear.
Okay, thank you very much for your introduction. We are now going to start a TURP. Standard TURP, monopolar TURP will do it. This is a 72-year-old man, had retention of urine. He is on catheter The neurological deficit has been excluded, MRI of spine, everything done, and we will do a monopolar TURP with glycine, which is the basic science. We learned like that. Now we are doing bipolar also. Prostate side is 51 gram, and ecotexture is normal, PSA within normal limit, and per rectally also it is grade 2 plus, and feeling is benign. So I have chosen monopolar TURP because this is the basic thing. A urologist learn first monopolar TURP. So we want to show that. It's all right. Anything you need? Ready? A telescope happening. Olympus happening. Star telescope ne? Normal ne? PSA bolo. PSA is 4 point kete.
Sir, the PSA is 4.6. The slight increase in PSA can be attributed to him being on catheter just after retention for 3 days. And he has a history of recurrent urinary retention, and he was taking alpha blocker since 2 months prescribed elsewhere. Then again he presented with retention, for which he is being operated.
Jaiji, telescope aane ko?
Was I audible, sir? The post-void residual urine, 15 days ago was 411 cc.
400 plus.
411 cc. 411 ml of post-void residue was there prior to catheterization.
Hawai, hak. ठीक अरे लाइट सोर्स लाइट केबल टा कहीं देलो देखलो एटा लागछ ना आउट लगे पड़ियो और ऊपर कनेक्टर टा दरकार पड़ी
Yes, sir, you are audible, sir.
लाइट केबल टा कहीं
Yes, sir, you are audible, sir.
लाइट केबल ना
Sir, the
एबड़े खुला
sir, ideally we can give a trial without catheter after starting alpha blocker.
लगे ना तार स्टार
Yes, sir, your question is taken, sir. Ideally we go for a trial without catheter after starting alpha blockers for 5 to 10 days. Different institutes have different dictums like what they follow, but this patient, he was on alpha blocker therapy for 2 months, and still he was undergoing retention. Multiple episodes were there. The last episode was when he presented to us, and then we had suggested him TURP for the same. PK Mishra sir wants to give his insight on this.
Hello. Am I audible? I am Dr. Mishra. Am I audible? Yeah. Just I wanted to give a clarification on this. How long we should? I mean the possibility of giving a boarding trial in a patient who was presented with acute retention needs a bit of clinical insight. For example, if a patient has come with a retention after a precipitating cause, for example, withholding urination, after an alcoholic drink, after a cough syrup, so those are the typical patients where a boarding trial is likely to succeed. And if the gland size is small and the retention has a precipitating cause, then probably boarding trial is worthwhile. Otherwise, acute retention of urine in this patient he had a chronic retention because his residual urine was 400 cc. So there is absolutely no reason why you should go for voiding trials. In these situations, probably we need to find out whether there is any atonic bladder or not. If the bladder is not atonic, it's better to correct the bladder neck obstruction, which is caused here by the BPH. Am I clear on this point?
खाली ऑपरेटर थी बोटे पड़ाला हेडा अरे भीतर रोड
Hello?
हेडा दे
Is it audible?
हेडा ऑपरेटर नहीं ना आर ऑपरेटर पड़ाला नहीं डायलेटर दरकार नहीं रखो देखिए था ऑपरेटर नहीं ये भीतर ऑपरेटर पड़ लगे
Yeah, the question is if you are wanting to give a voiding trial, it is better to put them on some alpha blockers. And alpha blockers have different time span to start working. For example, silodocin is the quickest to act. If you are putting them on silodocins, barely 24 hours, 48 hours, it starts acting. So the voiding trial can be given even after 48 hours, 72 hours if the patient is
सीजर
on
नहीं
silodocin.
डायलेटर दरकार नहीं
But if
सीजर
there
दिया
is,
ठीक है एडा टिक के ओपन करिए
and in this case, in case you want to give a voiding trial because you had a chronic retention, you have to give time for the bladder to.
2 hours, one can give the voiding trial.
Yeah, can give, provided that it is in silodocin and the bladder is normal. But in this case, he had a chronic retention. I mean, a voiding trial need to be give adequate rest to the bladder to recover. So that should be ideally be 2 weeks, 3 weeks. For that, there is no point giving voiding.
डायलेटर
I believe we should move on to the instrumentation part. You can Dr. Panigray can show you the instrumentations.
कैमरा इधर लाओ भाई 20
Yeah, he is doing that.
रख दे रख लगा yeah where this is this is a receptoscope of which make stalls no? This is a receptoscope we are using with a visual dilator. This is the telescope part. We are using 30-degree telescope. This is the visual dilator, obturator, visual. Under vision we will go in. This is the receptoscope, continuous irrigation type receptoscope. This is the outer sheath, the inner sheath, and this fits into the outer sheath. Then we are putting the dilator, visual obturator. Then we are putting the telescope inside. This is the telescope. This becomes a full receptoscope set. It is connected to the camera system. We have got a very good camera system. We have got Olympus to show that receptoscope, this cautery machine, and this is the Olympus camera head. This camera is connected to a Sony monitor. We have got a medical grade Sony monitor. The vision will be good. His meatus is little tight, so I am trying to do his meatus is little tight, so this 26 French scope is not going. So we are trying to do a meatotomy. First we will calibrate. It should go easily. 28 French should go easily, so that it won't be having post-operatively, otherwise they will end up in metal dilation. Last. This is 12 by 15. Then you give me that scissor. So, we are doing a ventral myotomy with the so that the scope should go easily. Yeah, we can dilate. We can dilate with I dilated. Then there is a Otis urethrodome we are using, that we are not using now. A camera system, take care. Now you see the camera. Now I can take out the obturator. That part is over. I will take out the obturator. I will put the direct working element. Hold it. Yeah. Give me the working element. This is the working element with the loop attached. Show the loop. This is 24 French. This is the loop, cutting loop. We are putting the telescope inside, and the loop will move like this. This is a thumb operating system. This now whole setup is now clear. You see the vision, under vision. I am not now going inside. This is the verumentanum. Is it visible clearly? Okay, I am focusing little. नहीं देख देखिए सफा कर दा देख चले बाहर कर एडा सफा कर एडा सफा कर सीधे फोकस करा दो बाहर हाँ बस हाँ बस वेरी गुड system in the modicito Olympus. Now it is better. Hello. Are you able to see the verumentanum? The vision is good. Okay. Now it is all right. This is the verumentanum. This is the prostate. Both the lateral lobes are little. Both the lateral lobes are little enlarged. They are opposing each other, kissing each other. It is grade 2. Then we are going in. You see. Now this is there is no median lobe enlargement. ଆମର ଚଷମାଟା କାଟିଦେଲେ ଦେଖି ଚଷମାଟା ପୋଛିଦେଲୁ ନହେଲେ ମୋ ମାସ୍କଟା ତଳକୁ କରିଦିଅ ନାକ ତଳକୁ କରିଦିଅ ସେ ଏଇଟା ପୋଛି ଦେଇଦିଅ You see, this is both the lateral lobes only enlarged, median lobe is only bladder neck is little raised. Then this is a bladder. You see the trabeculations, multiple trabeculations, grossly trabeculated bladder with few saculi. In between trabeculations, you see the pouches. This is the evidence of chronic retention. This is a chronically obstructed bladder. There is a bladder outlet obstruction, significant bladder obstruction. So he will get benefit out of this TURP. Suppose there is no outlet of this, no trabeculation, means acute retention may not be due to the prostate, may be some other reason. So now we find the evidence that there is a bladder is highly trabeculated, means there is a outlet of a significant outlet obstruction. Now this is the veru, this is our limit of resection will be up to the veru. So we will just put cartridge on. Cartridge on.
Yes, sir.
What is the setting? Cartridge we have made, we have put the cutting current on 120 and coagulation 60. We raise it to 80. coagulation we raise it to 80. 120, 80. Standard. दे मत सुन है नॉलेज देखा जे कुछ असुविधा नहीं दूर कुछ असुविधा yes thank you. You see now the Veru is the limitation, lower limitation, and upper limitation is the ureteric orifices. I will show you the orifices. You see the orifices, left side ureteric orifice, is it seen? Hello? Hello? Anybody from the visible?
Yes, sir, visible.
This is the right ureteric orifice is here, dimple is there, the left ureteric orifice is there. So this is the limitation. We should not go beyond that. But now there is no medial lobe, so we will keep it here only. So just I will put one tag marks at the Veru, just touch it so that you will not. Okay. The Veru antennum is here. So this is the test as well as the marking. This is there are two marks. The resection will be up to this only. And at the 12 o'clock also we put a mark so that not very much needed, but just because it is a workshop and training, we don't do mark, go on cutting. But usually this is the ideal to see, because anteriorly this is length is small. You see anteriorly length bladder neck to the mark is small, very less, and at the base means floor it is longer. So better you mark it so that you will not. Should I start cutting? Is all right? Anything to be clarified here?
Yes, sir. Yes, sir.
So we are now starting cutting, huh?
Yes, all right.
Okay, then.
Yeah.
Then I am doing the right lobe is more enlarged, so right side I am doing first. So chip by chip, first half we will take at the neck, we will make it wide, then we will cut the apex area. Now you see, you are seeing the capsules at the bladder neck. These are the glistening fibers you are seeing. These are the capsule. This is the capsule. So once you reach the capsule, don't try to go beyond that. These transverse glistening fibers, white glistening fibers you are seeing, this is the capsule, true capsule of the.
Yes, yes.
So now
Perfect.
I will go gradually. Unless once you see these transverse fibers, be cautious. You should not go beyond that. Then you come to the next step. So first half is cut. Now you come to the next level up to the apex. You see, I have made a cut here. I have a marking. So my limitation will be up to this only. Don't go beyond this. Proximal. This is from side. That side is distal. This is the cut. This is the marking I have given earlier. So after this I will cut it. Then I will little scoop, little more tissue is there. So very good setup here. Many thanks to Apollo and Dr. Samal's setup. Now you see small stone like things are coming. So this is the inner limit, the floor side. You should not go more than this. Once you see the stone like things, small concretions, this is the depth of the cut. See? Are you able to see small things? Small black spot. They are the prostate.
You injure the capsule.
Yeah. Nothing to worry. If you injure the capsule, there will be little sinus space open. Then be speed. You cut the speed, nothing will happen. You see, you have to speed up your dissection, come out, give a traction. That will take care of. So it is not alarming. You see, once you injure the capsule, deep to the capsule is venous sinuses. So there is chance of opening. Venous sinus opens means there is an intravasation. The fluid will go inside more. And there may be, but because now the pressure is raised, intravesical pressure, now it will not bleed. It will not show you because they are venous sinuses. If the arterial bleeding, sprotter there, you coagulate immediately. There is a small shutter here, I am not coagulating, I will go up. Now you see the side, almost right side gland is gone. Right side gland is gone. I will just little do it. Then I will go to 12 o'clock. I loaded the scope to 12 o'clock position. You are getting my point? This is the commissural area. Both the lobes, they come each other.
Yes, sir.
So I have given a mark here. You see, this is the mark I gave first at the 12 o'clock position. So I have come to this level. I should not go beyond this. Otherwise, sphincter will be injured. Always, the basic thing is always you should see the loop. Blindly, you should not cut. Once you experience you are cutting, but you see there is a bleeder here. There will be big bleeders at 12, 11 o'clock, 11 to 1 o'clock. And as you go on, the bleeder was earlier seen at 12 o'clock. Now it has come to 1 o'clock. So 12 to 1, 11 to 1 there will be a bleeder, and 5 and 7 there will be a bleeder. So those bleeders if you take care of. So I am carrying little. Then I am coming to the left lobe. The right side is almost gone. See, this is the veru, this is the marking I gave to cut it. Then little tissue I can take out later. Now coming to the left lobe. You see the 12 o'clock is over almost. Then coming to the left lobe, I have given the marking here. So I will limit up to this point only. See, there is a floor vessel is there. Once you see the sprotter, you immediately coagulate. That is better. Don't wait till the end of the. This is 7 o'clock bleeder. This is 7 o'clock bleeder. This is arterial bleed. So arterial bleed you must coagulate immediately. Otherwise, your vision will not be clear. Now vision is clear because I am coagulating immediately. Here is the mark. No, that is not. Still, you see, here is the mark. In bigger prostate, we do a retrograde cut also. From the mark, you go back. Here is the mark. We can go back also. You see, I am going back. Then coming from down. I can do that. That is also possible. But yeah, pushing the like whole we are pushing the gland. So TURP is the bread and butter of all urologists. This is the bread and butter. Initially you go on doing TURP only.
My other moderator was asking
Sir.
whether antigrade or retrograde, which is better, pushing or pulling?
No, pulling is better. Never try to learn antigrade because I am 40 years practice I am doing. Earlier I never did.
That is physiological.
Now we are doing because we are confident of where I am, where my loop is go. My hand is, this is a precision cutting. If you do retrograde cut, you should not learn. It is my sincere advice. Youngsters should not learn. You see, this is a coordination, hand movement and cutting, the depth is a coordination work. What you are seeing, what I am feeling here is different. The stone area has come, small stones are there, this prostatic calculi. So once it comes, it is the depth we have reached. The sisters are very well trained. They are lubricating in between. Very good thing.
Stones,
Sir?
does it lead to malignancy later on?
No, they are actually intra-gland, once gland increases, these are the calculi, prostatic calculi you tell, concretions, they are inspissated secretions. They are small things at the level of posterior capsular area and glandular area. So once you reach this interface, you see these are the concretions. Once you reach this interface, you are between the glandular enlargement, the gland adenoma part and the capsular part. So you should not go beyond that. Once you go, the capsule will be injured. You see, this is the white capsule. This is the capsule. This is the, you see, this is the concretion. You see, I have just separated it. You see. So this is the level where you stop cutting deep. You should not go. If I am cutting, I am just very lightly I am doing, not putting the loop deep, pressure, no pressure I am putting. So it is only just scraping, that is okay. But if you go on cutting beyond this, then you will end up in venous sinus, opening a venous sinus.
So here I have a question for you.
Sir, tell me, almost I am done. You tell me.
Here I have a question for you.
Sir.
Do you make a stroke like this arrangement? Stroke.
Stroke, sir? I didn't.
The proximal part, if we make a stroke, if it is done in a sloping manner,
Sloping manner, yeah.
that does not.
If I go on cutting from here to here, one long chip with a slopey like this, you mean to say like this? The cutting like slope like this.
No, proximal border.
This is the proximal one, bladder neck area.
I mean this part.
This is the bladder neck. This is the proximal portion of the prostate. This is the distal. This is the apex part of the prostate. This is distal part of the prostate. We always think from above, not nearer to the Bheru is Bheru. Near the Bheru is the apical portion of the prostate. This is the apex of the prostate. So near to the Bheru, yeah. Tell me, sir.
Yes. So this pattern of sloping manner.
You can do.
Making a reach. Instead of making a reach, you make it a slope.
No need. You see, at the Bheru, you must be very, very cautious. Now, this is the splinter, you see. This is the splinter. No. You see, this is the splinter. This is the Bherumentanum. If you come little below, we are likely to injure the splinter. Then he will have incontinence. So here you should do very gentle resection at the apex. This little apical tissue also you can leave it, no problem. This will behave like a cushion, so that he will not have incontinence. Suppose he has got, this is an elderly man, 72 years, he might be having some neurological issue also. We don't know. This has been almost it is proved. There is no, but you see, this is a beautiful cut here, cut margin, all round, at one level only. The below and apex, above. This is below same level, above also same level. If there is little hanging tissue, you can coagulation. Don't try to cut it, so that the margin will be healthy. Don't put your cutting current here. It is just a margin where I am giving little coagulation current. It is only 80 watt. Now you are convinced the cut is smooth. There is little tissue here, but I am not trying to cut, because this little tissue doesn't matter. You see, it's not coming also. If I am putting the loop, it is not coming, because it is adherent to the capsule. This is the capsule, hardly any depth, hardly anything left here. So we should be very, very cautious in TURP. The most dreaded part is incontinence. Incontinence, patient comes with retention, but he is continent. He will never mind to hold a catheter, but he will mind to put a bag or a pad. Incontinence he will never accept. Nobody accepts. Incontinent patients are socially abandoned. So I am now taking out the chips, then I will evacuate and see. Okay? Somebody please help. This bucket is full. You take out. Hey, come this side. Hello, Babu.
भैया इधर से लेके
इधर आ जाओ.
उधर ले जाओ
इधर आ जाओ. तुम इधर से आ जाओ ना.
दीदी इधर नहीं जाना
We will shift to the second OT
Ida
for
dheere nahi
commencement of our
धीरे
second case.
धीरे slowly. आश्री. मत कहो ना टिके उठी भी कुछ ऐसे नहीं. हाँ. ये लोग ओरिया नहीं समझते हैं. हिंदी वाला है सब. पहाड़ से पोल. हाँ. दे. एवाकुएटर दे. हाँ. Okay.
Am I audible at the auditorium, sir? Hello? Sir, we will shift to our second OT. Dr. P.K. Misra sir is going to commence that case. I will present that case, and then simultaneously both the cases shall proceed.
You see, just so I am taking out the chips. There. Okay, that's you. पड़े ऊपर से पे बड़ चलो
Hello, sir. Are we audible? Second OT.
20 French catheter, sister. 20 French catheter, two-way.
Sir, yeah, we will commence with the second case.
Three-way तो होगी. सब two-way दिए.
Here we have a 60-year-old
three-way दे दिया तो
male patient.
irrigation करेगा.
He basically presented with the right loin to groin pain, and then he was evaluated and we found there is a 16
Now see, all the chips are out.
millimeter calculus
Am I
in
audible?
the upper and mediator junction, and the HU value for the stone is 1400 HU. So
ठीक है, कोई प्रॉब्लम हो तो बताना. तुम लोग इधर, ए ग्लाइसिन ओपन दिस.
Hello, am I audible in the auditorium? Hello,
Amresh, am I audible?
hello,
Amresh? Ajit?
good
morning, Amresh.
Am I audible in the auditorium? Am I
Ah,
audible?
with whom you are talking? Okay, okay.
Hello. Okay, thank you.
Now we are with integration in 42.
Okay, okay, good.
Someone please inform Ramana Bay that few moments will get back to you.
Okay.
Yeah, so I believe that I am Dr. Rourkela. It is in the OT2. We are planning for a
Didi, sister,
push
come here.
PCNS or a RIRS
Get the ball.
depending on the situation. We have a stone of around more than a centimeter size located at the junction of the upper and
There are
mid
two people
ureter.
assisting me.
Somebody
In
can
my
show
setup,
you
no assistance. I go on doing that. You are
the,
no
showing you
assistance.
the CT picture
Actually, because you are idle, no?
and
Everything. No need actually. You see, bladder is okay.
as you,
The audio to 42, like we are getting two voices here. Both from 41 and 2. We need either 41 or 42.
OT1, if you are listening, just I am finishing. So, give the concluding, I will put catheter and come out.
don't mix the audio.
It is
of
all
both
right
the
now, seeing anything to be done.
video. Now who is the
Ah, yes, Amresh. It is okay.
Excellent, sir. Wonderfully done. Very good channel created. Absolutely no bleeding, sir.
No bleeding. I don't give also.
Wonderful, sir.
Thank you very much. This I am closing actually. I am just,
Absolutely no bleeding.
I am doing little coagulation. Then I will put a catheter and come out. Usually in my practice, I don't give irrigation, no traction, no irrigation. Only 20 French catheter and come out. So, but they have given me a 3-way catheter. So, for safety purpose, we are putting the 3-way. If it is needed, we can go for irrigation. So, it is okay. I will come out. No issue. So, I am putting the catheter and coming out. Rest you can talk. Routine practice, I am using 20 French polish catheter, two-way only. No traction, no irrigation. If you are little cautious in cutting and coagulation, then no need of actually, you don't expect any bleeding. Maybe little bleeding, but it will settle down. Okay? I am coming out. Urethra is healthy. There is no injury to urethra.
Absolutely zero bleeding, sir. But for those who are beginners and
Beginners, we are also beginners. You should be cautious from beginning. You see the stream? You see the stream? You see the stream? Camera is gone, no? Chalo. Yeah, catheter diya didi.
not visible, sir. Now we can see, sir. Someone please focus.
Gotte glycine salla.
We showing the outside
Ketra salla?
focus on
Two. Two. हाँ ठीक है.
can you, is it
जल्दी दे.
Good morning, sir. Excellent development.
Catheter you can remove after 48 hours, but you can keep also 5 days, no issue. It is up to you. Usually I remove at 48 hours. So I am putting a balloon balloon of 20 cc. This given sister 20 cc. 20 cc balloon only. Then if traction is required, if there is a bleeding, you need to put a traction. Then we can put little more balloon and put a traction. It will little cap plug it.
Right side, right side, right sir.
चलो हमारा सरीगला then we can see that side what is happening देखिए था ब्लीडिंग बेसी हो कि एले गोटे 30 क्रमिक एडवर्ट मागम 30 क्रमिक थ्रेड सर्कल कटिंग क्रमिक एडवर्ट थ्रेड सर्कल कटिंग क्रमिक एडवर्ट needle holder
30 दे
and tooth force okay
Hello.
better
Am I in the
थोड़ा कर दो
मेरा
कैमरा source
है ना मिल जाएगा
light source sister telescope yeah. Okay
you can switch up the outside view and give the end of view.
yeah चल ले ये कोड़े लारे पण इसले तो ओके तले पकड़ना ऊपर सेपटे हैंग कर सेपटे कोड़े हैंग कर दो साइड रे मेटोडेम करछ ना सेटा विल पुट स्टिच
Ureteroscopic.
हां नहीं
Am I audible here? No. My audio is on. Hello. Hello. Is it
Sir, is the endo view from OT2 visible?
audio? Am I audible? Are you giving the end of view? Getting the end of view? Okay. So by now what we have done is we did a cystoscopy. We found okay. Yeah. So we have already done a cystoscopy and tried to put a
Sir,
Are you seeing the end of view now from this theater? My audio is on? Is my audio on?
sir, are you audible, sir, down there? Okay, sir, okay.
Okay.
Are you audible down there?
Are you able to access it? Okay, when just adjust it. Thank you. Thank you for the feedback. Am I audible now? Not audible. Audible now? Okay. So what we are finding is we have gone through the ureteroscope, trying to grow through the ureteroscope. The guide wire has gone to the ureter, but is not able to pass through the stone because it is impacted and it's coiling there. So now I am trying to go through the ureteroscope so that I can push it back. So two more maneuvers I will do. I will try to put the head end down. Can you put the head end down, pass another guide wire and try to enter. So we are put. I am not able to go by the side of the guide wire, so I will take help of another guide wire to stabilize. Did I do? Yeah. Did you cut there again? This is the right ureteric orifice, you are right. There, enter, give it, keep giving, do, done it. Yeah, tell me, any, there on the, pull it out. Okay. Nikalo. So we have put two. Can you see that we have got two guide wires now? One guide wire we have put it earlier, and another one is through the ureteric orifice. Now the ureteric orifice gets traced between the two guide wires, and it's very easy to enter. So this is the. So we have got into the ureter. We are advancing slowly, put a bit of irrigation. So we have crossed that iliac vessel curve. Now we are going up, going up, going up. You can see. So there is a kink here, which we are not able to negotiate through the iliac guide wire. Never Siam. Can you see the Siam? So now you can see that we have passed the guide wire and trying to push the stone to the pull out this guide wire. So now you can see the stone. And you can start lasing it here. Either since you are, can you get the laser? Come out. Yeah. There was Siam. Can I see the Siam? I believe we have pushed it back. Dekha? Show me thoda. So this is what the situation. It has gone.
Gone up.
The stone has been pushed up. Can you see the stone? It has gone up. So what do you want to see? Well, we can do a PCNL now, or else we can do a RIRS also. So give me a zebra. So what I am planning to do is, I have changed the guide wire to a zebra guide wire. I will try to push the access sheath. If it goes easily, I will go ahead with RIRS. If it does not go, we will go for a PCNL. Is that okay? Yeah, I believe the best will be probably RIRS any day because it's less traumatic. Yeah, can it little up? Take little up. Little up. Yeah. So I am coming. I have dilated this ureteroscope. Supposed to have dilated the lower ureter also. So I will try to put a. The stone is here only. The pani. The stone is here. It has not gone up. The laser there. That is will start breathing. Laser. So I am coming out. Can I see the CM? Yeah. You can see the. Can you come little down? If the stone is there in the upper ureter only. गाइड क्या करेंगे जेली जेली तो जेली inside. It's a male patient, 60-year-old. Jelly, hey, pani de. So we are going by the side of guide wire and guide wire. Are you seeing the endovision? No. Endovision, no. Give the endovision to them. ये vision चाहिए वो जल्दी से. Are you seeing? यहाँ फोकस करो, नहीं दिख रहा है ना, बोल रहा है तो दे आर टेलिंग नॉट सीन बोल रहा है. Are you able to see the
End of view,
end of
can you
video?
hear the end of view? Get the end of view? Are you able to get the end of view? Hello?
No, we are not getting the end of view. We are only getting the outside camera. Sometimes they focus on the monitor, sometimes here and there.
ये नहीं आ रहा है. आसो नहीं है फिर.
Now we can see the monitor and
just request to get in, not able to see the view. Fine. No, eraser. Their vision to they are not able to see. Are they able to see now? They can why?
we can see the monitor view.
Okay.
Someone is holding the camera.
Okay.
We are not getting the direct interview.
There is some problem. They are working on it. Let's see. So what we have done is, the stone is still at the level of the ureter only. I am trying to lace it through. Because of the kinking, it's not easy to push it through. Are you able to see the laser fiber now?
Yes, sir, we can see.
So what is the setting now? Give is 110 though. Yeah, I need to try with what? Web 15 minutes. You are giving it.
We are using holmium laser.
Is it a holmium laser?
In the
Someone please focus on the laser machine.
Can somebody focus on the laser? में?
कैमरा लेजर में दिखाओ. ये
पानी देता रहा. ओए, पानी देता रहा.
We are using a litho holmium laser set at 1 joule and 15 hertz in dusting mode.
So they can focus into the screen now.
Now we will shift over to the screen. Sir, this is the quanta machine, sir. Quanta machine litho model.
Pardon? I couldn't.
Sir, we couldn't get you, sir. Can you be a bit loud?
Can you tell me the question?
Can we change the mic in the auditorium? Amresh sir's voice is very much clear, but current speaker's voice is not that much clear.
Complimenting you, sir. Very excellent demonstration. The stone is being dusted.
Is trying to boy, there is some difficulty in locating it. I mean, putting the, because of the angulation, there is a difficulty. That's why I'm not able to go fast. But then we are gradually progressing, yeah. And it's fairly big stone. It's going to take some time, so we have to keep patience. If the stone slips back, we will go with a flexible ureteroscope. Now I am with the rigid ureteroscope till now. So the difference between lasing a ureteric stone and lasing a kidney stone is we need to go in the center of the stone if while we are tackling a stone in the ureter. Whereas if you are tackling a stone in the kidney, you can always go in the periphery of the stone. Pani, लेते जाओ. Pani. Can the excursion is in GNS panel, no? Okay. नहीं नहीं ठीक. I'm not getting the angle, so I will prefer to go with a flexiscope now. Otherwise, I will damage the ureter. Spinal anesthesia, yeah. Stand by. देखो CM. I'm coming out. I will try to put an access sheath now. If the access sheath goes well, then I will go with a flexi and try to ledge it off. इसको लगाओ यार जल्दी. इसको लो. इसको लगा. दे ये दे. Access. So just to continue the discussion, screen is blank, no? Nothing is going on here now. At the moment, I am trying to put the access sheath. Will be showing it. Trying to get an access sheath and put it. Yeah, I will show you. हट दे वहाँ से, हट दे. आप थोड़ा हटो. access seat though. Access seat. What is access? Can I? Okay, am I audible? No. So we can. Even the big upper ureteric stone is a bit of problem, and there was. You can listen to. Are you audible? Am I audible?
Sir, are we audible?
लोड करके दे सिर्फ लोड करके दे नहीं you are audible. So what I'm trying to put in access seat, can somebody focus here? So this is the access seat 911.5. This is a different, yeah, this is a fan seat. Fan seat means of the 10, 12. You can put a suction here also if you like, and we can. So let's see if it goes in. You can use fans. Jelly, come in, come close, come close, come close, come close. Jelly दो. फोकस कर रहे हैं इधर. सियाम कोई दिखाओ. सियाम. No, it's not going. नीचे देखो नीचे. गया क्या? ना कॉइल हो गया देखो. देखा? नीचे नीचे. नीचे. I believe it's not going. It's not gone in. So I believe this thinner access seat is. This access seat is not going. So what do we do now? I will try with a thinner access. Dekha? It's not going. Can you see? So if it is not going, there is no point forcing it in. This is 10. This is 10 friends. Dekha? It's not going. Could you get me? Can you see it is getting stuck there? I am getting a resistance, so we will not put this one. The other one আছে? Seat আছে ছোটটা? He was lazy it, but then it's not possible to push it back. Let's see what putting it. Hey, is anybody listening to us? If that does not go, what I will do? Supposing this goes, it's fine. But if it does not go, then I have got what options I have got. I believe we have to just tent and come out and try it the other day. Hello? Am I audible? Am I audible? So basically I am trying to get a thin, I am getting a 9 French access seat, if it is possible. से access seat रे ureteroscope जाए तो, flexi जाए तो. जाए सर. ना हमरो छोटा रे ureteroscope जीवो तो. Yeah, visual पहले पानी. It is important to soak the access seat before trying to put it in. because of the activate the hydrophilic coating. बाहर 9/11. So try, is anybody showing here? Dekha, Siam? Yeah. Can you see the Siam? Do you know? It is barely. Dekha. Dekha. It's still not going. Could you see the buckling? It's happening. Dekha. It's not going. So I have got. वहाँ कौन है डॉक्टर पटनायक है ना क्या यूरोलॉजिस्ट की ऑफिस से काले काले जेली हेलो you can see me so you can see there here. So I'm trying to put the double the stand. Do you agree with me or you want to do something different? Hello? No, there is a small kidney stone as well. Urologist Dr. Amresh. Dr. Yeah. We could have put the flexi through the guide wire to do, but I personally avoided that for two reasons. One is there is a kink there, so it may be difficult to access it. देखा ऊपर देखा उठा देखा even the guideway this is becoming difficult. देखा 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 no we're in trouble now. छान ना गाइड होता देखा दादा नीचे देखा the guide or asleep. Yeah. Can you put the guide or bhitor ko pura gently asta asta देखा see me here देखा दे going guide or edge na okay just the running देखा देखा तो से एक्सेस फिट पूरा आई मीन नाली है था नाली अभी तरह देखो बैकलोड का अब पूरा तो भीतर पूरा भीतर पूरा बैकलोड इधर भीतर बाहर ला कानूनी लालटा बाहर कर दे just wait it go it's always am I audible there Dr. Patnaik? Dr. Patnaik, am I audible there? So, flexible in endourology. So, what I am trying to point out is, it's always very important to become flexible in endourology so that, then so that you are not getting into trouble. It's always easier to stent and come back next day and it becomes a cakewalk rather than to injure the ureter and देखो see so CR yeah. Now the guide wire has gone. Can you show there screen? So the guide wire has gone, the stone is still stuck in the upper ureter. I believe we will leave it there, just pull out the guide wire, pull out. So we'll maybe come out after 3 weeks, it will be dilated and by that time it will be easier to do a RIRS. Since it is a stone which is not possible to push it back, I had no option of doing a PCNL also. It is not in the upper ureter. Antegrade PCNL would have been an option, but then this is quite low down. It's not in the upper ureter, it's in the junction of the upper and middle ureter at the level of L3, L4. So I believe it was the best plan will be this. We'll come back again someday after 2-3 weeks to do a. So do you agree with the plan or you would have done something different, Dr. Patnaik?
Absolutely, sir.
You're right.
Not at all, sir. I agree with you absolutely that to come again after 2 to
Yeah, much better. Right. So there is no point unnecessarily trying to meddle with it. 16. So moral of the story is you need to have all armamentarium at your disposal. You need to have a good team and you would have the open mind to change the plan whenever required. Any question from the any question? No. Still call it up.
मेडिकल मेडिकल ग्रेड मशीन का सब हो गया। एस वीडियो तो क्वालिटी कम है, क्वालिटी कम कौन हेलो सर।
माइक मेरे पास है।
सर यू वर सेइंग एनीथिंग?
हेलो।
Yes, we can hear you.
ओटी चेंज हो रहा है, रुकिए 1 से 2 में जा रहा है तो हिलेगा ही।
Yes sir, we will just start the relay from for the third case. Just 2 minutes. Yeah, I will give to Mr. Sir. Sir,
Hello, Amresh. Amresh, I am audible.
Am I audible?
I am KK Panigray, Amresh. Okay, we are starting a stone case. Okay. No problem. लेट अपन लोगे हाँ ये अरेस्ट करिए तो कम मिलोगे मत दरकार नहीं सीआर
Hello, is it audible now?
मत सीआर में दरकार नहीं
Hello,
कौन करी ये तले अच्छे स्टोन देखिए
hello.
ये भारी है तो
Tell me. Yeah, tell me. Yeah, tell me. Phone. Yeah, please. Okay, just transmit me the question. Hello.
ओके हाँ के वीडियो लगे थे सेपट सीटीटा बाहर कर दियो केवी भी एक्सरे लगे दियो
Yeah,
बर्तमान दरकार नहीं सिया
I'm listening. Tell me.
तळे सिस्टम हमें
Hello.
यू आर सिंपल करिया
Yeah, tell me. I'm.
यस ठीक है
हाँ.
हाँ बेटा सब सती आधार कार्ड बेटा सपोर्ट कर दे बेटा सपोर्ट
I am in the second OT. Yeah.
Sir, Dr. Shruti Ranjan is asking, how can we know that when, yeah, so Dr. Shruti Ranjan is asking, how can we know the patient is in supine or prone position from the CR image itself? This is the first question. And the second question is like, is there any way where we can assess pre-operatively whether the ureteric orifice is patulous enough or ureter is patulous enough to allow the process of ureteroscopy or RAS?
Yeah, that's a very important question. In fact, in the C-arm there is no way to judge because you can rotate the image. So whether the patient is supine or prone, which one is upside, which one is downside, you have to assess on the table itself. You can put a towel clip or an artery forceps on the view and make it and rotate the image in the C-arm so that you orient yourself. Usually we put the head end in the upper part of the C-arm and the leg end in the lower part of the C-arm, and the left right we orient ourselves. And as far as assessing the ureteric orifice, whether it is patulous enough to admit a say access sheath or not, it is not possible because it's all depends on the distancing capacity of the ureteric orifice, not on the size of the ureteric orifice in the imaging. In the imaging, the ureteric orifice size is around 4-5 French, and this instruments are around 10 French, 9 French or 10 French. So it's not possible whether the ureteric orifice is distensible. But to quote statistics, almost 70-80% of the ureteric orifices is possible to dilate it up to 8-9 French and put a access sheath.
It is attached now.
So you should
So that
always
X-ray first.
re-counsel the patient that there is a
KV X-ray.
20-30% chance
You go
that you will not be able to put an
dega,
access
yeah,
sheath safely in the. So
Go,
we'll
यहाँ लाओ भाई।
stage the procedure by putting a double
इधर
gestant,
फोकस करो
and
stone here.
the existence of the double gestant itself will gradually dilate the ureter. Could you get me?
कहीं
Hello? Hello?
only this one
Hello?
Very well said, sir.
So,
I think you have cleared all of his doubts.
so if you remember,
Yes, sir, we can hear you, sir.
if in gynecological practice, am I audible? Hello?
Amresh,
Am I
we are
audible?
going to start our third case.
Audible.
We
So
are
if you
going to
remember in
start our third
gynecological
case.
practice, they are used to
With a
something called
mid-ureteric
lamelluria
stone.
stent.
Actually, sir, we are getting
According to
audio
the
from both of
Oh, you
I
ask him
believe
to
there's
stop.
some hey,
बस है ना बंद कर दे
Acha, okay. So now Dr. Panikray will be telling you about his case. Okay?
चुप बंद कर बैठो चुप So it is audible now, Amresh? She is a lady, 50 years old. So there is a stone here in the mid.
we can see one image, sir.
Yeah, you see this image. This is the stone. There is a mid-ureter stone, already pre-stented. Now we will take out the stent and do a conventional ureteroscopy.
Please ask the cameraman to show it properly.
उधर जाओ हाँ, सीधा दिखाओ सीधा करो वहीं ले जाओ ना पास में देखो you just now you see the KUV film
Zoom in a little more.
zoom करो भाई और
Or enlarge the image, sir.
बड़ा करो
We can see it, but we cannot appreciate the finer details.
और थोड़ा बड़ा होगा क्या पास में लाओ इसीलिए बोल रहा था Camera.
Now we can see it, sir.
Okay, this is the stone. You see the stone? This is a elongated 18 millimeter. Clear? The stand is there. Now we will take. Yeah, we will take out the stand.
Yes, now yes.
And we will go for a conventional ureteroscopy with lithotripsy, with pneumatic lithotripter. Suppose the stone migrates up, then we will go for RIRS. Okay? Got my point, Amresh? So my planning is to take out the stand,
Sir,
go
before
for.
you proceed, if you, yes, sir, I can appreciate it.
Okay.
Everyone can appreciate it.
ठीक है. So we are taking out the stand and going ahead. एडर किसी दरकार नहीं एडा कौन करूँ
ଭାଇ କହିଲେ ବାହାର କରିବା ପାଇଁ
स्टैंड गाड़ी साना पुरुषम नहीं की दोनों साइड एडा कौन
ସାନଟା ଦେ ନା ଏଇଠି
छोटा स्टैंड रिमूवल फॉर सब दे
ସାନଟା ଦେ ଛୋଟ ଅଛି ଅଛି
छोटो फ्लेक्सिबल बोर्ड थिला
ଅଛି ଅଛି
हाँ
Describe a little bit about your instrument, sir.
yeah I will. This is only cystoscope I am now taking for removal of the stent. Then you will use Olympus ureteroscope you will use and with a lithoclast. This is the Olympus ureteroscope, 5 degree, 6 frames. There. Come here. What are you doing? Pani. पानी दे एट लगे होगी हाँ एपट लगा लगा कि दरकार नहीं तुम छोड़ी होनी तुम चिपी दो जोर रे वैसे चिपी होनी चिपले स्टोन कोड पड़े दे
ଜଲ୍ଦି ଦେଇଛି ଦେଇଛି
फर्स्ट देइछ दिल्ली देइछ see the stand right. Now seeing the stand in position. So first you see the ureteric orifice is okay. You will be able to put the scope.
Someone please focus on the monitor.
Focus on the monitor. So sometimes what happened when you put the stand and keep it for a longer time, the ureteric orifice becomes granulomatous and inflamed. In that case, it is a problem sometimes. Ureteric orifice is healthy now, and you see it is patulous. It is opening also when the urine jet comes, so there should not be any problem. Now I am putting the. Suppose ureteric orifice is unhealthy and looks granulomatous, then we try to put a guide wire first by the side of stand, then take out the stand, because once you take out the stand, the orifice may not be well visualized sometimes. So stent is out. Now give me the ureteroscope. Guide wire. Take out this. रिमोट स्टैंड दिखा दो इधर. See the stand. Taken out. Very well maintained stand. She is taking plenty of water, no concretion, nothing.
Yes, we can see that.
Yeah. So this is the ureteroscope Olympus make, 5-degree ureteroscope, 5 degree. You see the patulous ureteroscope, I am directly going in without putting guide wire. If I find problem, then I will put a guide wire.
Very well appreciated.
You see here the stone site is inflamed and leaks. So I am putting a guide wire then. I should not push. Stone is seen also here. Stone is seen. Yeah, stone is here. Are you able to see the stone white? Stone. Are you able to see the stone? Yeah, then give me the little drifter. No guide. Guide. Other guide wire they chada. Better. They. Yeah, I am just for safety guide wire I am putting. Though I am able to see, but it is always good to put a guide wire. Cut it. Yeah, they have made arrangements. So safety wire, guide wire, this is known as safety guide wire. I have put it. Is ready? You baku nahi ase machine na. Dushibo, paibo. Okay. De taku rakhe. Fix kar rakho, modi kar rakho. Modi diyo. हाँ. So by the side of guide wire I went up, I am going up and I am able to ତମେ ଏପଟେ ଆସ ପାଣିଟା ଦରକାର ପଡ଼ିଲେ ସେପଟେ ଉଠିକି ହଉ ଚେଷ୍ଟା ହେଲା ଦରକାର ପଡ଼ିଲେ ଯିବୁ କହିଲେ ବେଶୀ ଯିବୁନୁ नेगोशिएट करेगा प्रॉब्लम हो ठीक है हाँ बस दे କେତେ ରଖିଛ 10 4 ରେ ଦେ କସ୍ କରିଛ ତ 4.8 4 ଅଛି So I am on the chipe ଟିକେ ପାଣି ଦେବା କାଇଁ pulse you are now able to see the stone yeah little bit ଦେଖେଇ ଦିଅ ଟିକେ
We can see the stone, but we want to see the pneumatic laser drifter.
okay दे ଟିକେ ଦେବା ଟିକେ तुम सिलेंडर लगेछ कि हाँ तो ये नहीं कि जून एयर नहीं कंप्रेसर नहीं
We can see the pneumatic laser drifter.
pneumatic lithotripsy is the safest mode of braking.
Yes, sir, I can.
तो पेड़ छाड़ टिके छाड़ देना पड़ता है निश्चय किसी बंद कर एडे बंद करो एडे बंद करो टिके बस कर रहा करो बस रख मुझे ना so हार्ड ना सॉफ्ट टाइल भांगी होगी soal juga mungkin coba dulu ya apa ya soal juga ya
Sir, can you hear us, sir?
yeah tell me
Hello.
yes
Hello.
yeah you are audible tell me Amresh
Sir, here our senior Dr. Jyoti wants to ask you.
yeah tell me
Yes, sir. Yes, sir.
ah pardon
Sir, Dr. Jyoti, our senior,
yes
wants to ask you that when do you use rheumatic lithotripsy and when you use laser lithotripsy?
laser is little cautiously you have to use. If it is impacted stone, we first break it by pneumatic. Once it becomes mobile, means free from wall, you see this stone is attached to wall almost. You see, wall is unhealthy. If you go on breaking by laser, it can be done, but it might injure the wall. So laser is to be avoided in the impacted stone. That's the thing. If it is if it is a hard stone, then you can go for laser. This is a very soft stone. The Hunsfield unit is low. You see, it is breaking easily. If it is breaking easily, better you go with pneumatic lithotripsy. If it is not breaking, this is a black hard stone, then you go for laser. You have to choose this. Laser is heat producing. There is no heat here. In pneumatic lithotripsy, there is no heat. So urethral stricture chance is very low with the pneumatic, and is breaking easily. Pneumatic will be easy and fast, and laser will be very slow and time taking. You can use the laser, no problem, but it is impacted stone, it is big stone, and it is soft. So I am doing lithotripsy for better, and future also there won't be any stricture. Am I right, Amresh? Okay, thank you. Now passage is open. Now you see I am going up. See, the impaction is gone and nothing has migrated. I am going up, up, up. I am near the kidney. In the kidney. This is calyces you are seeing. Amresh?
Yes, sir.
Are you able to appreciate? So passage is one passage.
Into the kidney, sir.
Yeah, it is, I am inside kidney.
Yes, sir. So I think
I am.
upload for comma, sir. Write down the case beautiful.
Thank you, thank you, thank you. Then small fragments.
And here the upload here, sir.
Oh, okay, thank you very much.
Everybody is clapping for
Give me a syringe. This you will aspirate. There are very dirty materials inside kidney. So we are aspirating this. We will clean first the kidney. PC system, you see, I have aspirated the fluids. They are dirty fluids in syringe. So better to clear first. Then we will go for the fragments left. Yeah. So the capacity is 15 cc. So the internal pressure should not go up. So that post-operatively you see now it is clear. Kidney system is getting cleared. So 1-2 times you wash it, that is better. Then by gravity saline. So by gravity it goes. अरे झिया दीदी आसलु एटा पाथफाइंडर काट डायरेक्ट लगा एटा सालाइन देछ तो डायरेक्ट लगा ग्रेविटी रे जीव से पाथफाइंडर थिले चिपिया पड़ियो लगा बंद करी छी न एटा बंद करी खाली हां चट ठंडा छोट कौन ताप ना फिट हम ना तो बड़ हेल्ले सी ना ऑटोमेटिकली इट विल गो इफ यू पाथफाइंडर इज देयर you have to give pressure. So without using pathfinder, I removed the pathfinder. Now urine saline is going in by gravity, and I am washing the PC system. It comes slowly. So that is better. I don't use pathfinder. No bleeding, nothing. Yeah. The guide wire is below, it has not gone up. Just for safety purpose I have kept it. Now the fragments, small fragments you will see, this will come out. If there is a big fragment, I will again blast it. These are few bigger, still it is smaller. This will come by the side of stent. They are, you see, they are small. They are all fragments, they are attached to wall. Give me forceps. Give me a forceps or basket, something like that. A forceps. Tripod nahi. Tripod tripod है. Alligator forceps धरियो नहीं भलो. Space मारी बसी हो कहीं. Tripod दे. For the sake of showing, I will take out few fragments. They are smaller. They are magnified views. If you put a stand, it will come out. ट्राइपंग दे लगी जी they are flying inside. I will take out few fragments, 1-2 fragments for showing. Patient will be satisfied my stones are out, and these are the small fragments which will automatically come out by the side of stand. So tri-prong is better.
Right.
You see, tri-prong also it breaks. I am holding, it becomes two pieces now. So these small pieces, you need not bother. If it is a bigger piece, I will see. You see, show me, cameraman. So these are very small pieces.
Yes, sir. We can see that, sir.
Okay?
Yes, sir.
So if I don't take out also, nothing happens. Basket achhi tomara?
basket వచ్చి keyboard basket
Huh?
నా already
Dormi hai, co basket.
basket వచ్చి first
So I am saying I am able to go also. The ureteric orifice is well dilated. Ureter is also dilated. If it is a bigger stone, I will blast. Otherwise, I don't think any blast is needed. No more blast is needed. They are small things. Materials by the side of stent it will come out. So you see, ureter is very unhealthy. If you use laser in these cases, there is a chance heat may pass to ureteric wall, and there is a trauma. And there may be future stricture. Here I am 100% sure there won't be any stricture. There. Yeah, first of the day, Aditya piece card.
Right.
खुली रचना ठीक है बंद करे ये खराब है बंद करो बंद करो स्टैंड
6 number
6 नंबर
6 number
There are very small fragments, not holding also, very small. So I am putting a stent and coming out. Stent deva diyo. Okay, it's all right. I am putting a 6-French stent little wider because the ureteric orifice and ureter is dilated, so that it will remain open. After 6 weeks we can take a X-ray. 6 weeks we can take a X-ray and see all the fragments out.
zebra देती ना
Wait, record. Then once cleared, the stent can be out. If some fragments are left while taking out the stent, we can remove those.
Sir, is it your routine practice to put stent in all URSL cases?
No. If it is 100% clear, single small stone, it comes out, and there is no stone in the PC system, kidney, then better don't put stent. Stent, if there is a fragments and there is a chance of inflammation, and to avoid the post-op pain and sepsis, we put stent. It is not routine. It is up to the choice, situation. It depends on the situation. Many cases we are not putting stent. Now, like PCNL, we are doing tube free. Ureteroscopic also we are doing it tube free. Release kar. ఎప్పుడు దేవా లీటర్ కట్టి దేవా కడిగి దేవా क्या नहीं बहना एटा दे मुझे एटा देखो ना सेटा दरकार नहीं रे किसी दे पड़ेशिव ना see I am putting the guide wire retrograde way and taking out the guide wire cystoscope working channel and putting back and look सब डेरी आहुरी फास्ट हम केस दे so pani guide wire is in position. Now we will taper a de stand दियो So 6 French stands, both sides open stand, we have put it and going very easily, because the advantage is it is a pre-stented case. Earlier the stent was there and everything was dilated, healthy. Take out the guide wire. This stent is in position now. Appreciate? Okay? Double the stent. Amresh? Catherine?
You can see the CRM image.
CR you want? What do you want? You want to see CR with any stone fragments? CR we have not used. I am not using CR. We want to protect ourselves. Okay, if you want, they can show you. See, we have not used the lead apron, so we are not using. Please.
Only for the audience who want to see the upper coil of the stent.
Oh, upper portion of the stent. It is 100% in the kidney. There is no obstruction. I didn't felt any obstruction. So, of course, where is the CR fellow? Just put and so. The apron देखे दियो स्टैंड इज अब दरकार नहीं रेकड़ सब कर दियो खाली स्टैंड देखे दा तो बिंदु जा बिंदु से तो दरकार नहीं पड़े से देखे दो बाबू एटा कर दियो स्टैंड पके देखे दियो जे स्टैंड टा पोजीशन अछि you want to see the stent in position whether it is gone up and coiled in the upper calyx or not in the pelvis. इच्छा बन गई तो जा एक्सरे बाहर करियो नहीं दरकार पड़े देखो मेरे को नहीं चाहिए पहन लो उसको दे दो मेरे श्याम शेयर में दिखाओ भाई उधर से लाइट बंद कर दियो ये लाइट थोड़ा बंद कर दो कहीं लाइट करो ए रो चलो कहीं लाइट करो से बहुत हाँ रोटेट करो सीधा करो सीधा 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 हाँ यस यस उल्टा ही गला उल्टा 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 यस ओके 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 हाँ गो अप लोअर कॉइल दिखा दो पहले नीचे आ जाओ थोड़ा ब्लैडर एरिया दिखा दो पेल्विस टाइट कर दीजिए हाँ देखा ओके
Sir, there is a question for you from the audience.
या टेल मी देखा थोड़ा घंटा देखो ऊपर घंटा देखो टेल मी रामरेश आई एम ऑडिबल I am able to hear you.
Sir, Dr. Srikant here.
Huh?
Yes, sir. There is a.
Yeah, tell me. You see the lower end of stand?
You are audible, but there is a time lag, sir. So,
Okay.
Dr. Srikant here wanted to ask you, sir.
Yes. Yeah, go ahead. Upper end दिखाओ. Are you able to see the lower end of the stand? Amresh?
In pre-stented patients,
हाँ.
can USWL be done in ureteroscopic?
USWL, this is in the pelvic area, mid-ureter.
Now you can see.
Yeah, this is a mid-ureteric stone, so USWL is not advisable. Upper ureter you can do it. कौन हो इधर लाओ ना इधर लाओ अपर ओह मूवमेंट नहीं होता है क्या देखा देखो एक्सपोज करो सी लिटिल उसके ऊपर नहीं जा रहा है उसको रोटेट करो ना चलो ओह अच्छा अच्छा ओह ओके ओके नीचे लग गया सी अपर ureter ठहरो Amresh, are you able to see the upper coil of the stand? Amresh, you can see the lower coil and upper coil, both are in position. And there is no stone by the side of stand. This is, what you are seeing this is her BTL sling. This is BTL. She underwent BTL laparoscopically. So these clips, clips are there. So another clip is here also. I saw checked in the KV X-ray earlier. There is no significant stone here in X-ray. What we have seen. This is the lower coil. This upper coil is well circulated. This will come down also. It will become straight, and this coil will be little more. So any clarification? Anything you need? ESWL can be done, but it is not ideal in the mid and lower ureters.
Very well done, sir.
Yeah. So thank you very much for appreciating. So I am out. I am going out. Thank you. Thank you. Thank you. Everybody, thank you. My job is over. 2 cases I have done.
Thank you, sir, for your excellent demonstration.
Okay. Welcome. Sure. Open karo. I am in hurry. No. My flight is there in 2:45. I have to go back.
कैमरा बाजू में तो नहीं। थैंक यू सर।
Hello. Sir, are we audible from the fourth case? We are going to start the fourth case now.
Please go ahead. We are ready.
Stent is there. 6 pain. That mass पर वो एक्सरे के ऊपर देखो छोटा फ्रेगमेंट देगा ना बात क्यों ले स्टेंट का जड़ का रन लगा था ना स्टेंट लगा दिला इंपैक्ट दिला सिर्फ लगी जिसो तो देखिए वो स्टेंट का लड़ तो चेक किया उसको लगा ना स्टेंट का लड़ था कैसे ले
Hello, sir, are we audible from the fourth case? We are going to start the fourth case. Are we audible down?
You are absolutely audible here, and we are getting one image of maybe 4 OT here.
उधर नहीं आ रहा है ये ऑडियो उधर आना है ना नहीं आ रहा है Sir, the fourth case is a case of right upper calyx 10 millimeter calculus and who has been pre-stented. And the patient is planned for right side RIRS.
Can you show us the image?
Hello.
Yes, sir, will show.
Hello. এটা কাম করছে এটা
They can hear you.
you can hear me. We are planning to RIRS in this case. This is very sorry the X-ray. We are able to see the X-ray. Are you able to see the X-ray? There is a small stone in the kidney. It has been pre-stented as well. So we are planning to चेंज करो एटाके चेंज करो
थोड़ा पड़े पूरे बंद हो जाଉଛି
Am I audible now? Hello? Hello?
Yes, sir. You are audible.
Am I audible? Okay, so we are planning. You have seen the X-ray. Did you see the X-ray? Did you see the X-ray? Did you can see the X-ray? There is a small stone in the kidneys, and it's a pre-stented ureter, and we are planning for a retrograde intrarenal surgery. Dilator. What is the dilator? This stricture. Yeah, can I present the patient? Can just they are asking again. This patient is a 42-year male,
Yes, sir.
which presented with
Right flank pain.
right flank pain, and had an upper ureteric stone, impacted stone in the evaluation. We had a stenting about 2 weeks back,
No, 3 weeks.
3 weeks back, and now is for RIRS. So what we dilator देना, dilator देना, So there is a stricture in the lower in the urethra, which but not as no, we have not gone inside. There is a stricture in the submeatal part of the urethra, which is not allowing the cystoscope in. So I am trying to gently dilate it.
Technical person, can you please focus on what Mr. Sir is doing with urethra? Because such cases may happen during the surgery.
So is it end of view? Are you able to see the end of view now? No. Somebody can focus here. Is it see? Yeah, please go on. Yeah, they are fixing it on. They are doing something so that they can directly transmit the end of view rather than the. Are you able to see the end of view now? Are you able to see the end of view?
No, sir. Now the screen is blank. We can see the outside view.
Focus here. So now again, so the ureteroscopy, the right ureter stent is there. We want to plant the, take out the stent, and before that I want to empty the bladder, so that there is no DJ removal for sir. छोटो for sir, DJ removal for sir. Sometimes it does not come to the focus. Advance. Are you able to see? So there is no. डीजे रिमूवल फुर्सत नहीं है. नहीं होगा डीजे रिमूवल फुर्सत. दूसरा वाला जोटा देता अन्यटा खबर है जाऊनी तो बोले विजन रहे देख लगे So it's always better to do a rigid ureteroscopy before we do a RIRS. Am I audible? Am I audible there? Hello?
Agreed, sir.
I am audible?
Yes, sir, you are audible.
So it is always advisable to do a rigid ureteroscopy before doing a flexible ureteroscopy. The reason is to find out the health of the ureter. Is it healthy?
ଏଇଟା ପଡ଼ିଗଲା ଆଚ୍ଛା ଆଚ୍ଛା ଏଇଟା କ'ଣ ୱାଟର୍ ପ୍ରୁଫ୍ ନା କ'ଣ ଆଉ ଗୋଟେ ଥିଲା ପରା କ୍ୟାମେରା ନାହିଁ ଏଇଟା ପଡ଼ିଲା
Oh, I see. Hello. Hey, come.
ପାଣି 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 ଦେ ପାଣି ଦେ
Let's go. Am I audible? So we will be doing a rigid ureteroscopy before we put the access sheath. Not see distended area. It's distended. Cystoscopy. नीचे धैर्य jelly guide wire you cut terumo nahi jelly kidney tray नहीं guide wire you cut the zebra the you cut give you rotary cut zebra zebra shear now shear me guide wire यार you come in it go ethi ne asa so that it will be easier you stand behind me give Yochi देखाओ श्याम yeah you cut thata you are a part the guide wire hello access it
Sir, we can see your part.
এটা খোল এটা খোল give me that एक वोटा कर दिया right so we'll now pass the access sheath over this guide wire access sheath কোড়া এটা বলা যায় সাকসেস
We can see that.
yeah we are now trying to pass the access sheath over the guide wire jelly there with jelly see here niche so now the guide wire you can see the access sheath going up hello
Please show the CR image, sir.
can you see that image show that image
You have to see the CR image.
are you seeing it now CR image
Yes, sir, we can see now.
you can see the guide wire over there we have passed the access sheath and now I am removing the obturator and the guide wire See, show me again. Show me share. Share me image. Shoot, shoot. Yeah, you can see that. So this is almost gone into the kidney now. Ideally, if you are not using suction, there is no need of putting the access sheath to the kidney.
Yes, sir. Okay.
But in this case, there is a provision for suction. Will you show that hands now? Okay, guide where though. I mean, you cut. I mean, flexi. Okay. So this will be.
We have to see the fan sheet, sir.
Fan sheath you want to see. So show me here, show here. So the basic difference between a standard access sheath and fan sheath is this provision. Can you see here? Are you able to see?
Yes, sir.
So there is a provision to put a suction here, and that goes to a collecting device, and we can put intermittent suction. And there is a stopper here, so that there is no air entry from this side. Whereas the normal access sheath is like this. Can you see the normal access sheath? So the end of the normal access sheath is like this. There is no suction device. Okay.
Yes, sir.
मुंह देखिए केमती come here, hold that.
Please show us the flexible scope before you introduce it.
Yeah, this can you just show here? Let us it लगा. Hey, come moves here. Put it. अच्छा ठीक है. No issue. Yeah, can you show here? Are you showing it? So this is the flexible scope we are using. This is a biorad make, and you can see this is a logic. This is a intuitive or logic ureteroscope. That means when I am putting it up, it looks up. When I am putting it down, it looks down. So this is a intuitive or logic make of a ureteroscope. So now it can hold this one. Now we have cleared of glycine side X. So it is easy. It is better to wash the ureteroscope. Let us hold this. Yeah. So put here. इसको दिखाओ. अच्छा, it's relaying endo view you are seeing. You are seeing the endo view. Hello.
Yes, sir. We can see it.
So I am inside the kidney. I'll gently withdraw a little. There is Cyan. So I am verifying in the Cyan that I am in the upper calyx, and now I will withdraw it. Withdraw it bit, and I am trying to see the lower Cyan. Seeing the middle calyx, that's also not there. I am withdrawing further, and can you show me? So what is happening is I am inside the kidneys, but not able to. I am trying to locate the stone, which I have not yet done yet. Chalo, put some dye. Put some dye. The lower calyx. Cyan. Middle calyx. Just search it out. I am in the ureter. going inside.
Dye.
Dye. Give some dye.
But I think the patient is very narrow look for to
Let's see what it is the situation now.
Push करो dye.
Push. Dye. Shoot. So, bas, that's all. Put into the oil. देखो सिया
The audience here wants to know why did we do full contrast?
Yeah, basically we want to delineate the pelvic alyceal anatomy. So once we delineate the pelvic alyceal anatomy, I can go to the each calyx and search for the stone. Could you get me? देखो, see.
Right.
So I am just entering the kidney, and now I will देखो, see, I am not entered yet the kidney. देखो, निकाल देता हूँ इधर बैक करना इसको ये कवर पुट इट देखो गाइडवेयर देना इसका गाइडवेयर डोंट पुट प्रेशर वहाँ प्रेशर देने की जरूरत नहीं कम पानी पानी दे Funny. Come out of Ureteroscopic. Come out of the system and we are not able to negotiate back. Find it there? I am not in the right place. ये देना टेरू मगर जीवन दे पासे धर पासे Can you see the Siam? Siam? Yeah. There. So could you appreciate the kink here? I am in the system now. Okay. देखा देखा दो देखा देखा Where is the stone? Is it what is देखा
Someone please focus on the CR monitor and the end of you want the end of you and the CR.
they can die now. Where is the I mean, can you show me the stone shadow? Just show me again. Show me again. Shoot. I don't know. दिखाओ show me again. दिखाओ what is this? Is it a shadow outside the system? Move करची ना नहीं but it is in the kidney or देखो जी
The shape of the stone is also like little odd.
yeah
It is ending here.
So is it a calicial could you or maybe inside some of these infundibulums not able to enter guide what? Let me enter this narrow infundibulum. It may be lying there. Dekha, can you see? Is it going to the stone? No. Is it going to the stone? Dekha? Is it going to the stone? Achha. So that means it just hold this tight karna is. That means the stone is in this infundibulum. Its mouth is quite narrow. Now where is it? And it is. Can you see the C-arm picture? Are you able to appreciate the C-arm picture? I mean, we are inside that infundibulum where the stone is seen.
I think you are on to the stone, sir.
Stone, but there is no stone seen. That means what? That means
Yes,
it's a calcification rather than a stone. Parenchymal calcification. But he had colic, you told me, no? So I have Siam again. So I am on to the shadow in the Siam, but I am not able to see any stone here. So we'll call it a day. Why to state on this? If it is a calcification, there cannot be better way of delineating than this. Parenchyma. Calcification of the parenchyma. It's this narrow infundibulum we will again see if it is. Can you put the guideline?
Before you come out,
I believe we will see this, we will laserize this and maybe enter this narrow infundibulum and see. Is it okay? Is it seeing? It's this infundibular narrowing and stone. So laser there. Give laser. So we'll give an incision in this infundibulum and try to
possibly, sir, it is in that
infundibulum. Most likely it is in this calyx with a narrow infundibulum which is barely admitting the yeah. It is.
Sir, you can see the clapping, all the audience is clapping for you. Managing such a difficult case, sir.
It's a difficult situation. Dekho, again, Siam. No, I'm not there. There. Is it around the stone? No. Around the stone, no? So this is that narrow infundibulum which is housing the stone. So we'll laserize it, laser fiber. इसको निकाल देते हैं एक मिनट हाँ या नहीं so this good. So, well, 110, make it 1 and 10.
What point you want to give the incision?
Yeah, this is. I mean, if you If you think of the anatomy of the vessels, the infundibulum is a very tricky place actually because the vessels are crossing it. So we want to give incisions of at this not at the up or down, not at the suppose this is the clock. I don't want to incise at the 12 o'clock or 6 o'clock, but rather I want to incise. Where is that? Okay. Lost it. Can't get it. Sit. दिखाओ तो श्याम कौन सा था गाइड वाले क्या देखा this one no no there is a big देखा क्या कर रहे हो सिटी में देखा तेरा सिया स्टोन नो नॉट इन द स्टोन ना स्टोन अच्छी around the stone? No. Sure. Penny? देखा स्टोन वेस है पानी incident put this another one yeah
Yes, sir. This is the calyx you have incised.
yeah but not could not incise properly just tried to incise and then I lost the देखा yeah this is the calyx which contains the stone पानी so I believe you have to incise further
Yes.
I can get in I am trying to get in gently if I can so देखिए I will not lose the sight so guide where the laser दे give the laser ये बेटा देखिए मत कर There, there, advance. Advance. Laser on. On. Ready? Honey? Keep giving water. Honey, take care of honey. 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 Take care of. Pump नहीं कर रहे हैं. This one. Space is so narrow, I'm not able to focus the beam into the septum I want to cut. I'm gradually seeing the stone now. Yeah, this is a diverticular stone or I am trying to take out that film surrounding the diverticular wall. If I can do that, I will be able to laserize it. I'm almost there, I will be doing it. Funny. Now I am able to see the stone in some. Is it the stone? No. No. I'm not sure. देखाओ तो सियाम. Yeah, I'm on to. But then, yeah, am I able to see the stone, or it's still a? Is this a stone? Yeah, this is the stone. A very odd calyx. Not a,
Yes, sir, that is the stone.
yeah,
But at 9 o'clock position.
at the 9 o'clock position, that's the stone. So we are trying to enlarge this septum of the part of the wall. If I can laserize this part of the wall, I'll be able to. Now the septum has to go, and somehow because of the this is a ureteroscope, which is the laser is coming at 1 o'clock position. I find it very difficult to localize. Yeah. So now we are on the stone.
Yes, actually, sir, there are two types of stone, for right and left technique.
Yeah, those are luxuries, people discuss. For us, we have to tackle whatever is available. Yes, sir. Fun. A big stone.
This is like take the help of anesthetist to
It's on spinal anesthesia. Unfortunately, he's in spinal, no? Yes. But then he is cooperating quite well. So I don't want to disturb him by saying something. The patient is cooperating. I believe it will be tackled. They become more conscious of it, and they want to say unless panic. I believe got this one. This. But if I rotate the scope, will it be better? Basket will be also no easy. I've almost done it. This thing should go. Now you want to update also this portion. So what you assume presume to be easy is very difficult. I thought it will be a cakewalk.
This is real difficult doing it in spinal will also make it
I
more
see.
difficult.
More difficult, yeah. But then it's being done, hopefully. And I think we are going to tackle it. Trying to focus on it. Liquid. Barota baj rahi hai na? They can go ahead with the inauguration while they are watching the country. If time is a constraint, it's going to take some half an hour time. Kung kautsum. No, he's allied, no? Patient is allied. They can. Yeah, Avinash. Hello. Rotate it.
Yes, sir, we can hear you.
I was thinking of rotating the scope so that.
Can you break most of the scope
No, not
and take 15-20 minutes more?
more, yeah. I'm trying to rotate the scope so that, but then that does not work. A stone, what is the laser mode? What is the setting now? Hard stone. But what is the setting? What? Energy? 1. And frequency? 10. 12. So when you find a small stone in the upper calyx, hello, Dr. Patnaik, are you listening me? Are you there? So if you find a small stone in the upper calyx, you should always suspect of some anatomical abnormality, that why it is not dropping down. Either the infundibulum is narrow or it is in the calyxal diverticulum. So
This one I don't think like we thought in the beginning that it's impacted ureteric stone and migrated there.
no. It is there only. The colic may be because of some other thing, maybe another small stone which has passed. So that has confused the picture basically. But anyway, upper calyxal stone one has to be really careful. Pani?
Yes.
ये लेजर स्टैंड बाय हो गया क्या? रेडी? Ideally this should not protrude like this. Sometimes the stone in against a narrow infundibulum can also cause colic. Maybe that was.
Right, sir.
No, what do you think? This is a calyxal diverticulum or it
What
is
is your choice for a calyxal diverticular stone? If you have a mini PCNM or
I believe
if you know it like pre
if I know pre-op, I will prefer to do a mini PCN. But then it is, if it is upper calyxal, you can try also this. This is not bad actually, less traumatic, but then I am more comfortable with PCNL.
I agree.
But then PCNL has the trick of making a good accurate puncture, and many times you may not be able to park your guide wire, but if you park your guide wire, the job is done.
Yes.
This is probably a calyxal diverticulum in most, in all
Most of the diverticular stones are superior
upper polar, yeah. Yeah, they are. I mean, it can occur in all pole, but upper polar calyxal diverticulums are commoner. So what do you expect me to do? Should I laserize the diverticular wall as well to make it non-secretory? They are as such non-secretory. I have done away with the stone hopefully now. This is okay?
What is your preference, sir?
What I have observed is, I mean, it has if you put it in high frequency, it becomes difficult. You should put it around 8, 10, and the power should be around 1 or 0.8, and that's probably the best setting in which the stones can be tackled. There are a lot of confusion in the literature, but then that's probably the best setting practically. 0.8 into 12 or 0.1 into 10, that's what I am using now. Cut off frequency. Frequency क्या था चले? 15. This is in dusting mode, and 15 and 0.1, 1. 0.8 and 15. Now this is what 12 watt. So I believe it's done. I believe we are done. We will put a stent and come out. Okay. Are you happy, Dr. Patnaik? Should I?
Sir, excellent, wonderful job, sir. Only thing I want to ask, like, before you come out, like, do you want to check by doing an electrostogram or RGP? Uh,
To check any extravasation or not? Well, no need as such, but then you can do always. If you want, you are suspecting something wrong or you are suspecting extravasation, but then
Yes, sir.
there is, if you have dot extravasation, there is no point documenting it. It's better, but you can do always. But then there is no clinical benefit out of doing a RGP now.
right, sir.
Extravasation is
We
unlikely.
are going to put a stent, so
Yeah, will, because all these fragments has to come out, no? All these fragments has to come out. Now these fragments are migrated to the adjoining calyxes. So we'll put, so it's, so I can just put a stent and come out now.
Sir, can we use that fan suction you are so?
Yeah, we can use, I'll just show you. So I have to come out to put the, can somebody laser, हाँ पूरा बेर करो ना, एक बेर करो, ये करो, ये कैप्ट दा, नहीं, don't take out. Yeah, now you can put. So can somebody focus on this cap? No, nobody is there. Are you able to see the cap in the tip of the access sheath? So that cap need to be put, and then the ureteroscope has to go through it.
Another person please show.
Is it saying here? So this cap,
Yes, sir, we can see it.
this cap need to be put, and then you can put the ureteroscope through it, so that you can make the suction effective. Otherwise, the suction does not become effective. Pani de. And the access sheath need to go to the system, PCS, which normally we don't want. Pani? Yeah. So now, now you can put the suction here. Suction is up. Suction is there. Suction लगा है.
Please show the suction. We don't need the CRNA right now.
इधर देखो. So this access sheath is connected. This access sheath is connected to a suction device and a receptacle. Okay. So you can regulate the suction through a valve here. Okay. So this is off now. You can make it on.
Yes, sir, we can see.
So pani de. So while giving, while applying the suction, we can all these fragments can be sucked. थोड़ा ये कर out. इसको थोड़ा घुसा. So while this is the future, I tell you, this suction, there will be further refinement on these suctions, and the temperature regulations, all those things will come up in another 4-5 years into clinical use. They are already in the developmental phase, and ureteroscopy is going to be the surgery of choice for stone now. PCNL has already started declining. Rate of PCNL in Western world has started declining, and RIRS is taken over.
Right, sir.
So now,
Right, sir.
so these fragments have been, to some extent, has been sucked away, but not all. But the only thing which I dislike about this sheath is, this sheath has to go all the way into the, cross the pugae, which is supposed to be the narrow part of the ureter. And or you can see the fragments which are coming down, some of them. You can withdraw all the way to this and then go in again.
Yes, sir, you can see.
Stand by. ऐसे निकाल दे. So I'll just put some irrigation and try to suck out whatever possible, and then I'll put a stent, and I believe we'll call it a day. Some fragments are coming actually. चलो पानी दे, पानी. अब मत दो अभी. I believe that should be all right. चलो stent निकालो. It was a difficult case some done.
Excellent job, sir.
इसको गिर गया.
Please give Mr. Sir a round of applause.
Somebody showing the Siam. Okay. Hello. I'm putting the stent without endoscopy. देखो. देखो.
Yes, sir, we are seeing that.
I will. So the landmarks are in the male, it is in the upper border of the symphysis. In the female, it is the pubic angle. It denotes the external landmark for ureteric orifice. Right.
Yes,
Sir, we'll go down and join.
it is place.
We will be coming down and joining you. Thank you very much for comparing.
Thank you very much, sir, for in such a